I'm Carol Paris, and what I guess by way of a little bit of background on who I am and why I got interested in physicians for a national health program, I suspect that there are people in that room who have been, I know there are people in that room who have been in PNHP longer than I have. I didn't actually go to medical school until I was in my 30s. And so I already came to medicine with a little bit of a different attitude, in that I'd been sort of a patient on the receiving end of healthcare, had a family, those kinds of things that just informed my the ideas of what kind of a doctor, how I wanted to practice and be. And then I went to medical school at West Virginia University in Morgantown, West Virginia. And that was in the 80s. Really, my medical school did not do a bang-up job of teaching us to be advocates in any kind of political sense. In fact, we were encouraged to be good doctors and take good care of our patients, but the idea of getting involved in politics was sort of, that's for other people to do. And one of my emeritus professors, I'm very happy to say, in his address to the medical school of 2003, I think, rectified that and said, it is no longer just our duty to take good care of our individual patients. It is actually our duty and our obligation to address the sort of the more public health and political aspects of healthcare. And so at that time, the early 2000s, I was in private practice, and but I was actually working for other organizations. I was an employed physician, and so I was kind of insulated from the realities of the business of medicine. And it wasn't until I opened a private practice in 2006 or so that suddenly I was wearing two hats. I was a psychiatrist, but I was also a small business owner. And boy, was that ever an education for me, to begin to see how the influence of the private insurance industry impacts my ability to practice in a way that I felt good about. And it was at that point that I just threw my hands up in disgust and said, you're never going to get insurance companies in this country to be regulated. You write a piece of legislation and you turn around and the regulations are written with so little impact on the insurance companies that either they do a workaround or they just say, all right, well, if you catch us, we'll pay the fine, and that's just considered part of, the cost of doing business. So it was at that point now, early 2009, that I just said, there's got to be a better way. And someone said, well, have you ever met Margaret Flowers up in Baltimore? And that was, we were introduced on Facebook, and that was the beginning of my half a year of mentoring in the policy and the research of single payer. I would come home from work every night and open my computer and read everything I could about healthcare reform, about single payer. And when I had a question, I would call Margaret, and did you know who Margaret Flowers is? Dr. Margaret Flowers,
yeah.
Pediatrician in Baltimore.
She's visited us several times.
Okay, good. So, then sort of where Margaret and I then intersected in May of 2009 when she called me up one Sunday evening and said, "What are you doing Tuesday?" And I said, "Well, I thought I was going to work. Uh, what did you have in mind?" And she said, "Well, how would you like to maybe get arrested at the Senate Finance Committee?" I said, "With you? Sure, let's go." And so that was, the opportunity to speak up at the Baucus hearings. And what I can say is that really was a pivotal moment for me in terms of just realizing that activism is the thing I needed to do almost for myself, to be able to put up with the nonsense that I was dealing with on a daily basis in my practice. And I really do consider that activism for me is an antidote to the despair and the frustration that I think so many physicians are experiencing as a result of having to deal with the insanity of our multi-payer system. So I'm sure I'm not saying anything that isn't news to any of you. But just so you know, that's kind of the skill set that I bring to PNHP as president. I'm not a researcher. I'm not an academician. I'm basically the child of Maxine Paris, one of 6 kids, and I'm the only one who repeatedly got her mouth washed out with soap because I was always talking back, and I was always the one who said, "That doesn't make any sense," and kept asking why. So now I'm actually proud of the fact that I'm happy to stand up at times and say, I'm sorry, but the emperor has no clothes here. And so what you've asked me to talk about is, how do we go on the offense now? So in 2009, when we had a Democrat for president and we had a majority of Democrats in both houses of Congress, what we were told is, well, it's just not politically feasible to pass single-payer legislation right now. So support the ACA and we'll get to Medicare for all later. Now it's 2017, and what are we being told now? We're being told, defend the ACA now, and we'll get to Medicare for all later. Well, I think it's time for us to say, nonsense, no more putting this off. We've now got 6 or 7 years of data and experience with the Affordable Care Act to show very clearly that this is a paradigm that is not working. And anything that the Republicans are going to do is only going to be to continue to use this failed paradigm of using public dollars to purchase private insurance and further privatize our Medicare, our Medicaid. And what they're going to do is they're going to try to convince the American people that they're going to reduce the cost of health insurance, which they may come up with policies that people can purchase that cost less than what they're paying now. But what they're not going to tell us is that the value of those policies are going to be absolutely worthless when you get sick and actually need to use it. And so if you were listening in on the Bernie Sanders and Ted Cruz debate, what you kept hearing is Bernie Sanders struggling. I mean, his job, I think, was supposed to be to sort of defend the Affordable Care Act, but he really couldn't do that. because it is pretty indefensible. The fact of the matter is, it is too expensive. It is never going to be universal. It isn't shifting the cost curve. And it's tremendously complicated and causing more and more of our workforce, mostly physicians, to leave practice, go out on disability, retire early, or become burned out physicians. The Surgeon General last year identified his two biggest concerns as the opioid epidemic was number 2, and number 1 was physician burnout. So I don't see that anything that the Republicans are likely to deliver to us is going to do anything but create more hardship for our patients, and a whole lot more headaches for us as physicians. So how do we go on the offense? I think the first thing is to just get very clear that we can't accept the messaging that is coming from Congress and unfortunately coming from the Democrats, who are trying to convince us that what we really need to do is just go on the defensive, defend the ACA from repeal, and then work real hard to get more Democrats reelected in 2018 and 2020. Well, I think that that's the wrong thing for us to do. We need to seize this moment and make it clear that the time is now, that the Affordable Care Act is a failed piece of legislation. And while we will defend it from going backwards, because granted, it has helped some people, we don't have to defend it at the expense of missing the opportunity to say loudly and clearly, this is a failed piece of legislation, and what we need is a national health program. And it's this lovely young woman standing up and saying, I'm a Christian, and my whole life I have believed that it is my responsibility to lift up those less fortunate than me. And she talked about the mandate and said, I'm a young person, I'm healthy, and I believe that if I have to be mandated to purchase insurance because that's what allows older people or sicker people to get health care, then I'm willing to do that. And what we really need is, and she said Medicaid for all, but what she meant was Medicare for all. And I thought, well, this is unfortunate that she said Medicaid for all, but what actually happened is that video went viral. That happened on a Tuesday or Wednesday, and by Saturday it had been retweeted and viewed 25,000 times. I checked today and it's now been viewed over 1 million times. And just today, she wrote an op-ed piece in the Washington Post, and what she said is, I was really nervous when I was speaking, and now that I have the weird experience of seeing myself go viral, I really want the opportunity to be more clear about what it is that I really want. And what I really want is a single-payer national health program. Oh my God. This is important stuff. One thing I think it speaks to is that young people, this is not a woman who is a sophisticated health policy person. She's a French teacher. She doesn't really understand a whole lot of the policy stuff. But at a very basic level, it makes sense to her to embrace a national health program. Now, for her, it makes sense at sort of a religious healthcare is a human right perspective. But I think we have to be prepared to also make the case for single payer to conservative Republicans who are not going to be swayed by that argument. But they are going to be swayed by the argument that a national health program, single payer, is fiscally responsible. So I think it's important for us to pay attention when we're speaking to who is the audience that we're talking to, and be able to make the argument for a national health program flexibly. So if I'm talking to, my Unitarian Universalist church, I can do the healthcare as a human right approach. But if I'm talking to a group of conservative small business owners, well, I think it behooves us to be showing them the Fix-It movie. I have to watch it myself so I can speak a little more clearly to it, but to be able to make that argument that makes sense to small business owners. And so what I'm saying ultimately is something that Margaret, an acronym Margaret uses, ICU, and it instead of intensive care unit. Number one, I is independent. We have to be independent of partisan politics. If we are basing our activism on the direction of a political party, we're not going to get to single payer, because unfortunately, neither one of the major political parties is going to deliver us HR 676 until we make it toxic for them not to. So we've got to be independent of them. We need to be very clear. So independent, clear about what we want, not just what we don't want. And then we have to be uncompromising. And what I mean by that is basically replace the ACA now with HR 676 now. No more later. How do we do that? Well, the fact that this young woman was first viewed on Facebook Live and Twitter, I think tells us that there is a whole new media available to us that works around the mainstream media that pretty much blacks out our messaging. And we need to learn how to use that technology. I'm certainly not the most comfortable person in the world even talking on Skype, but the other night I did a Facebook Live commentary on the Sanders-Cruz debate. Was it my best performance? No, I was actually really freaked out because I wasn't sure how the technology was working. But I'm not apologizing, because I just said, doggone it, I'm going to learn how to do this and I'll get better at it. And I think that's the message I want all of you to hear, is none of us are too old to learn some new tricks. We need to use the social technology that is the social media technology that's available to us to work around mainstream media that is not, they're still going to black us out because the mainstream media is in the pockets of corporate America. There have been a few opportunities to get the message out, and maybe that's a hopeful sign, but I'm not going to wait for ABC and NBC and the Washington Post and the New York Times to put front page articles and leading stories about HR 676. So use the online media that's available to us. And I think that continuing to the message is changing minute by minute. If I'm off of my computer for more than a half a day, I'm already behind. I'm already behind on what's the relevant news. So we've got to stay up on the news, and one way to do that is, if you're not getting Don McCann's quote of the day, please subscribe to that. He does such a great job of spoon feeding us relevant information on a daily basis that helps us in our ability to make the argument. And a couple of websites that I would also encourage you to if you aren't familiar with them, is Healthcare Now, which is sort of the sister organization to PNHP. And then a third one is healthoverprofit.org, which is it's not an organization, it's actually a campaign that Margaret Flowers has recently initiated. And what this campaign is really, it's not focused on research, it's not focused on policy development, it's really focused on using all the tools in the activist toolkit to get the message, single payer now, to get it out there to a broader audience of the American public. So not so much focused on giving grand rounds to physicians. PNHP does a great job of that, and it's an important job. But we also need people out there at the public library and at town hall meetings and whatever other organizations you're involved in, learning how to talk about single payer, not to physician professionals, but to everyday people. So I would say here, between February 18th and February 26th, our Congress is going to be in recess. If you have representatives in Washington State who are not co-sponsors of HR 676, find out if they're having town halls and go there and raise a ruckus. Ask them why they're not co-sponsoring the legislation. Oh, another important part is Bernie Sanders has not reintroduced his piece of legislation, his Senate bill. And actually what we'd really like is for him to be encouraged to introduce a companion bill to HR 676, which is not the bill that he introduced 2 years ago. So if you've got some free time and want to get on the phone, call Bernie Sanders' office and tell him you want him to introduce a companion bill to HR 676. Call your own senators and tell them the same thing. And be calling your delegates, your representatives every day and getting them to co-sponsor HR 676. I'm going to stop there because I imagine all of you have other ideas and suggestions as well for how to kind of take the message to the streets. But that's my message, is we really need to be on the street. And I'm literally on the street every Tuesday afternoon between 12:30 and 1:30, holding a sign and networking with the other activists in front of Senator Alexander and Senator Corker's offices in Nashville, Tennessee. I was at the rally, the Moral March in Raleigh, North Carolina this past weekend. And I went to that because there was going to be a large white coat contingent. Another thing, dig out your white coat. If you've put it away or you're not wearing it much anymore, dig that baby out. That is such an important tool in connecting with everyday Americans. They actually really do think that we as physicians, it's impressive to them when they see a physician holding a sign saying improved Medicare for all, messaging patients over profits. That has a lot of cachet. So wear your white coat when you go hit the streets with your signs. You have a medical school right there in in Seattle?
Yes.
Do you have a student chapter of physicians
Yes,
there?
Yes,
Now?
we do.
You do?
And a member of
Relatively
our board.
recent.
Great.
And our mantra is to expand it beyond health sciences to undergraduates. In fact, they're mostly undergraduates now, but also graduate students in departments that are relevant, like the Department of Economics. Because there's an economic issue that you mentioned that's going to be extremely important. School of Business, and so on. So that's what we love to do. And our main plan, our strategic plan, is to help that next generation to make an impact.
Okay, that is wonderful. I will tell you that one of my goals as president of PNHP is to increase the number of student chapters around the country. That was the main reason I went to the rally in Raleigh, was to meet students, medical students, pharmacy students, nursing students from UNC and Duke, and get those chapters rolling. This evening, before I got home to turn on Skype, I was with the Vanderbilt SNAP chapter. They were having their one of their meetings. They were doing a trivia contest on healthcare reform, and it was loads of fun. But the important thing is that they know that there are mentors for them to encourage them to realize how much power they have to define the kind of healthcare system they want to practice in, so that they don't turn into mid-career and late-career physicians who are burned out and irritable and getting labeled disruptive physicians or just walking away from the practice. I think that's a valid thing for us to be doing. So if you're encouraging your students, that's fantastic. And I'm happy to hear comments, questions.
Maybe my son Peter could chime in here. I know we're not very successful in the past of having started state initiatives. Vermont, for example, small state. But some of us are interested in thinking about how we could get a regional effort, a group of, for example, Western states that would include California and Oregon and Washington, maybe Nevada, perhaps Hawaii, to get together to make an effort for a single-payer system. And if several regions like that were to develop, that might eventually lead to a national plan. But I think there has to be some concordance, administrative concordance in getting it set up. So I was wondering if, at the national level, what has been the thinking of both? I know there's not been interest, for example, in Colorado as a single state cooperative initiative. It wasn't supported by the national. But have you had discussions in the board about regional efforts to get multiple states together to get a critical mass, a large population? Has there been any discussion of that, pros and cons?
The question is, has there been any thinking at the national level of encouraging regional efforts to pass legislation that could then be broadened?
Right.
And I would say that at a national level, we're never going to discourage a state from pursuing a state-based initiative. And that was how Medicare actually happened in Canada. What you're describing is sort of the next iteration of that, getting a couple of states together. Realistically, I think the likelihood of that being successful is slim. Certainly going to be challenging, and Vermont found that to be the case because it's just not a very populous state. I think that New York and California have a better chance at it because they do have so many more people living in the state. The other thing that state efforts do is it does build the movement. So again, I'm never going to discourage a single state or a group of states from pursuing this, but I don't think we're going to put a lot of effort into helping that along, because the way we're going to get the economy of scale that we need to absolutely make it certain that we're not going to run out of money is to have it happen at a national level. And I think just unfortunately, that's the struggle that many of the state plans have run up against. So it's important work, and I'm not saying don't do it. I'm just saying that what we're doing at a national level is putting the effort into making it happen at a national level.
I wanted to ask if, in the interest of speaking truth to power, if there has been any update in the statistics that we had originally based our challenge in 2009. We had stats that showed that possibly 30 to 33% of the money that was paid or expenses for healthcare were related to infrastructure and to the administration. And since the ACA, I would challenge that figure, and I would like to know if you know of any resource that can tell us what that new statistic is. And also the number of people that have died for lack of health care while ACA has been in effect per year versus the 45,000 people a year that were dying before the ACA came into effect. My guess is that that statistic has changed, but we really, I think our credibility and our ability to really challenge facts, we really need to have information. And I'm wondering if anybody at PNHP, we relied heavily on your data when we would try to debate other organizations or to bring information to people. And so I'm just wondering if you know if those fact sheets have been updated to post-ACA conditions.
If I can butt in, we also need a post-ACA bankruptcy study.
Oh yeah, and a post-ACA bankruptcy study. Bankruptcies and foreclosures.
My understanding is that on the bankruptcy issue, it used to be that when Elizabeth Warren and David Himmelstein and Steffi Woolhandler did the first research, it was 62% of personal bankruptcies were due to medical debt. That was actually one of the trivia questions that the students asked tonight. And I got it wrong because I said 62% and they said it's 52% now. Now, I'm not sure that that's actually, I think it may have gone down a little bit, but not very much. So the point is, I think the important point to make is that in other developed countries, the number is 0. That's the number of people who go bankrupt because of medical debt. So whether it's 52% or 62%, are you going to be satisfied?
Right, I agree with you. But the big number I'm really concerned about is the administrative waste, because that's where our dollars are really going. And all that burnout that medical providers are experiencing is based on the fact that they are being run ragged trying to deal with all of that complexity of administrative waste.
There's that lovely slide that PNHP has that shows the growth in the number of physicians and then the growth in the number of administrators of healthcare, which it's one of my favorite slides. I don't know that it's even worth it to try to drill down on a change in that number, other than to point out that when we have a national health program, the amount of money that is saved by eliminating that bureaucracy is in large part what's going to fund our ability to expand Medicare to everyone and improve what it provides to people. Another point that I think is worth making, and I actually made this point, I wrote a response to the op-ed piece in the Washington Post today. So if it gets published, one of the things I said in it, because this young woman, she made a statement at the end of her op-ed that was inaccurate. She said, I think one of the biggest struggles we're going to have getting a national health program is that doctors aren't going to want to make less money. And I think that's one of those myths that people have. And so I made the point that, in fact, there's a lot of doctors who are putting patients first. The majority of physicians want a national health program, and that by reducing the administrative waste, physicians get an automatic pay raise simply by eliminating the overhead in their practices. And that's based on research out of Health Affairs a few years ago that said every physician in a practice, whether it's a solo or a multi-group practice, would increase their income by approximately $55,000 or $56,000 a year simply by eliminating the administrative waste of dealing with multiple insurance companies. So I think we can, you can address it from a couple of different ways. Now, the third thing you asked about was the number of deaths. And that I know that David Himmelstein and Steffi Wohlhandler addressed again very recently. And if you go to the quote of the day, probably about 4 or 5 weeks ago, there was an article where someone questioned Bernie Sanders, saying that we still would have over 30,000 people dying in this country because of lack of insurance. And David and Steffi went back and actually said, if they repeal the ACA, that number is actually going to go up to more like 46,000. It was 45 before the ACA. So now it's more likely to be up around 46,000. And that is a published art.
You did point out that you have a fairly slim chance of getting state or regional single payer. What makes HR 676 any more likely?
What makes it more likely is that we have a better chance of getting the Congressional Budget Office to actually do the number crunching that will demonstrate that it is a fiscally neutral piece of legislation if we get them to do that in the correct way. Because yes, taxes are going to go up, and if that's where you stop the conversation, it's not going to look like a fiscally neutral piece of legislation. So you've also got to factor in all the money that's saved by not funding Medicare and Medicaid and the VA and the federal employee health benefits and state employees and all of that. So it matters how you do the number crunching, but at a national level, we can get the Congressional Budget Office to do that. But first, we've got to get the bill. We've got to get enough co-sponsors for the bill to move it into a place where there's even going to be the inclination to do that kind of drilling down on it. At a regional level, how are you going to get 3, 4, 5 different states to put those kinds of numbers together? Everybody's going to want to do it a different way. At least if we do it at a national level, we've got an organization, the Congressional Budget Office, that's what they do. They put the price tag on legislation. That's their job.
In the Western Washington area for the last 3 years or so, we've been working with other organizations to try to pull together to push, healthcare reform in a positive direction. And with this attack, the attacks on the ACA, there's a lot of space opening up and people coming together, new organizations joining the Healthcare as a Human Right Washington Coalition, something like 40 or 50 organizations in it now.
Over 70.
70. Well, in our last meeting, about 90% of the time or more was spent on defensive actions of the ACA, and many of these committed activists have been working on the ACA since 2009, thinking that that was a step towards single payer and so on. Committed people, good people, and now they're focusing on protecting the good things that did happen in the ACA. The other 10% of that meeting, we talked about using this opportunity to push things ahead and go on the offensive and talk about single payer and at the state and the national level. Sort of summary resolution was just put out by Lisa Mosqueda a couple of days ago. Did you see that? Where you didn't see it, but I was asking people here. But there's it's a resolution to use at the state and national level on the congressional delegation and Washington state legislators. There's a lot of whereases about what would happen if the ACA were terminated in Washington state, and then be it resolves. There's, I think, 4 of them, but the last one is the grand resolution is to do one of 2 things. One is to push for a single payer solution, and the second one I think is more of an apple pie thing, like a push for everybody in the state being covered by something or other. So I think our position of the single payer people at that meeting were we've got to take this opportunity to move ahead and go on the offensive, and I think the document that came out of that meeting was a good one. But anyway, I think all over the country there are groups like ours that are trying to work with people that in the past we had some differences about the ACA and single payer, and when you were in the caucus committee and so on, I'm sure you're well aware of that history. But I think the key is for us working together to fight for what we really need. So do you have any comments about how old people that weren't exactly all that friendly now need to work together?
Well, I think it's important for us to work synergistically with other organizations and other groups that are advocating for healthcare reform. And if they're organizing a meeting and bringing people together, I go to those meetings as long as they're clear that if I'm speaking, my message is we need a national health program. So I'm happy to come and defend the ACA from any movement backward. I have to do that as a physician. I can't let patients be collateral damage to partisan politics. But that doesn't mean I can't continue to speak and say what we really need is a national health program. I've been going to the Indivisible Nashville events, and Indivisible Nashville is that organization that it's right out of the Democratic playbook saying defend the ACA, period. Go on the defense. Do not go on the offense. And I just ignore them. I go to their meetings and then I talk about improved Medicare for all. And what I find is that at the local level, that's what everybody wants. It's only at the national level that move on, and all these organizations that are getting funding from rich Democrats, that may be the messaging that they want to trickle down. But when you actually go to these meetings at the local level, what you hear is that all of these people want a national health program. And so I think we just need to infiltrate their ranks with a very clear message that no more tinkering, and no more being told ACA or tweaks now, Medicare for all later. We just have to stop that narrative in its tracks and say, we can defend the ACA now, and we can repeal it and replace it with a national health program. That's what the American people want. That's what we need.
Hi, I'm Merle. Simple question is, have you heard in all of your maybe sampling of events going on in the country of not only going on the offense, but attack? They're talking about right now in the Trump vulnerability for his temporarily, I guess you could call it vulnerability, that 6% of your Congress people who are at home are Democrats who are likely to have town hall meetings. Now, if, say, a guy by the name of Riker has a town hall meeting, going on attack sounds a little bit better. And Seattle has had that tradition where we went after Wells Fargo and kicked them out. We went after 15 Now, and by direct action, we achieved an awful lot. So has PNHP taken an approach in any case or anywhere in the country where they actually attack?
Now that I'm in a leadership position at PNHP, I have a much better understanding of what we can do with the resources we have and the staff that we have. And I can tell you my recommendation is we need to continue to do well what we do well with the staff that we have. And that is the policy, the research, the professional education, and encouraging our student chapters. I think we need to work with Healthcare Now and with Health Over Profit to do the kind of direct action that you're talking about. We simply don't have the infrastructure and staff to do that. And I think it is absolutely essential to be doing it. And so I think that's why we need to work in coalition synergistically with other organizations like Healthcare Now, who is starting to do some work around town hall meetings, and Health Over Profits, where we're also talking about doing direct actions. The medical students at Boston University this afternoon, just before we went on Skype, I was looking at my emails, and Emily Henkels from our national office sent me pictures of the medical student chapter, SNAP chapter at Boston U. They got wind of the fact that Martin Shkreli, the pharmaceutical snake, was going to be speaking about medical economics at BU, and they, in a couple of hours, put together a protest to his presence on the campus at BU. And that's the kind of thing that we need to be able to do. And PNHP as an organization isn't necessarily the most efficient at doing that, but individual chapters they need to be able to act quickly and independently, and I would support chapters at doing that, and I would support student chapters at doing that. And I would support members of PNHP also being active in some of these other organizations that just have the infrastructure or the flexibility to do some of these direct actions.
So I was very glad to hear you talk about your responsibility as a physician to protect people against harm. And I want to say that in the broad coalition that this chapter is working with in Washington State, Healthcare is a Human Right, which is led by the State Labor Council, the approach we're taking is not defending the ACA in the sense of saying this is what we want and need. What we're trying to do is to fight every cutback, but it's not just the ACA. Our program is very clear in what we're carrying out to the congressional offices. We're defending the benefits under the ACA. We're defending Medicaid against the coming attacks to voucherize it, to turn into a block grant and all that, and defending Medicare. So it's the trifecta of Medicare, Medicaid, and the ACA, which is the message. And Merle, to your point, this coalition, in coalition with other groups, has been we've been focusing on the 4 Republican members of Congress from Washington State. There's 10 here in the House, and 4 of them are Republican. And so we've been focusing on those. What, David?
Look at the camera.
Look at the camera. We've been focusing on those, both with meetings, with letters, and with rallies. And so we're, trying to do all that stuff. But I just want to say that I don't think you used the word infiltrating, and I took that in a good sense. I don't think that single-payer advocates will be taken seriously in the movement building that we need to do right now if we are not arm in arm with those who are fighting against all the cutbacks. So we have to be there in the front lines with people to fight off all these attacks. And, as you say, carry our message. Now, the Healthcare is a Human Right Coalition, as David McClanahan said, we're right now trying to figure out how to defend against cuts and go on the offense. What do we really need? And there's another formation. I want to just ask if you're working with it in some way. It came out of the strategy conference in New York in January, and it's called the Labor Campaign for Single Payer. I'm sorry, what's the?
It's the one.
Campaign for Guaranteed Healthcare.
Guaranteed Healthcare.
Campaign for Guaranteed Healthcare, which is Healthcare
So
Now, Labor Campaign for Single Payer, NNU, and PDA.
Yes. And so my question to you is, how is PNHP relating to the Campaign for Guaranteed Healthcare?
Absolutely signed on to it.
Good.
And will be present in our white coats, marching with them.
Okay.
Absolutely.
Because what was distinctive about that, as I read the reports out of New York, was they are combining defense and offense.
Right.
Or actually, they put it, they're offense and defense, but in any case,
right.
They're doing both.
Right.
And I think we have to do both.
And I agree. But I agree, and we have to be very clear that our presence there is in support of defending, and it is to carry a message that the solution is a national health program. And I have not gotten any pushback here in the Nashville area from any organization that is self-identified as defending the ACA, period, telling me that I can't join forces with them because they want my physical presence there. They want me, they want my white coat, they want medical students, they want more doctors, they want more bodies, and we can provide that and we can't be muzzled, we can't be prevented
Right.
from very clearly stating that our message is we need to go beyond this to a national health program.
I misunderstood. I thought you were going to be with us physically tonight, so I brought a copy of the stuff that this Healthcare is a Human Right is delivering to the congressional delegation, and I'll ask David to
Send it to.
Yeah, I'll send you that so you can see
Right.
the way we've been doing it so far, just in the last month.
You're making an excellent point, and I don't know any way to say it more clearly that what I don't want to do is defend the ACA and stop the conversation there.
Right.
I am not willing. In fact, I was asked to speak at Vanderbilt Children's Hospital a couple of weeks ago at a rally where the organizer was very clear that what he wanted was defend the ACA. And I said, if I am not allowed to defend it and go beyond that to discuss the benefits of a national health program, then I'm probably not the person that you want to put on the podium. And he said, you're right, you're not the person I want. And he said, between you and me, I want a national health program. But the people who are asking me to put this particular rally together only want a discussion of defending the ACA. And I said, then I can't do that for you.
Not even defending Medicaid and Medicare also? Just the ACA?
This was just the ACA.
Oh, that's unfortunate.
Yeah. And that doesn't mean that I'm not going to show up for other things where that's the message, as long as they're not going to tell me I can't carry that message further and say the real solution is a national health program.
Okay, thank you, Carol, for talking with us past your bedtime. And
I'm going to turn into a pumpkin, so.
we really appreciate it. And maybe you can get out here to Seattle sometime. Who knows?
I would love that. I used to go out there to visit some friends in La Conner.
Oh, yeah.
And I would fly into Seattle. It's a beautiful area, so that's always a possibility, and I will be in touch if I'm there.
Okay.
Thank you for inviting me to join you tonight.
Okay.
Really appreciate it.
Thank you.
Thank you. Thank you.
Good night.
Good night.
Good night.